Okay, I think we should make a start. Can I start by asking if everybody on this side can actually see all the speakers? Because I'm not the most slim body chairing this session, and I know that people find it difficult to see through me or around me. So if you can't see the speakers, they can't see you. But so if you're content, we will start. Now, I'm John Boyce. I'm a sort of Moncade politician who spent or wasted his productive years trying to make policy in the British and European parliaments. And why am I here? Because you will see me as one of the obstacles to progress, I suppose. Most politicians are seen as obstacles to progress. Is that not right, Petru? But we're not really. We can be part of the solution as well as part of the problem. And I hope we can prove that to you during this session, amongst other things. But I'm here, of course, because Yola asked me to come. And Yola asks you to come, you come. I'm here too because I like patient organisations. I like to hear from patient organisations. When I was in government, some of the most telling arguments that came to me came from sitting on a patient's bed or meeting a patient on the stairs of a clinic and listening to what they were saying. And so this session, we want to hear from you. I was, as I said, a minister. People used to assume that if I was a minister, I must be a doctor. In fact, I had people saying to me, Dr. Boyce, and I said, no, I'm not a doctor. Oh, sorry, Professor. They eventually got the hang of it that I wasn't a nurse, I wasn't a manager, I wasn't a scientist. And so they politely asked me, well, what on earth are you? And I said, well, I'm a patient. And to have a patient as a health minister struck them as being odd. I want to suggest to you that patients are key to policy making because patients have an expertise which we need. I know, because I live with diabetes and heart disease and various other things you don't want to hear about, I know that I am an expert on those conditions. I live with them. My doctor doesn't. He knows all the textbook stuff. He knows all the expertise that comes from his experience over many years of practicing and working with patients. But I'm the one that lives with it. I'm the one that lives with the side effects. I know when I feel comfortable with treatments and therapies and so on. And that's part of the expertise we need to bring together. We need a partnership, and we've got you a partnership. No worry about the expense of bringing them together. They are here in front of you. And I will introduce them as we come to them. But I want you to look at these people because they are the experts who are going to have a word to say in a moment about their experience of personalised medicine. And then look at your neighbours, because you are the experts, and you're going to talk back. You're going to have your say, and we want to hear from you, please. So let's just think about for a moment what it is we're talking about. I said I had diabetes. Let's take one. And I go on day after day, after week, after month, after year, taking the same drugs, doing the same therapies, going for the same tests, taking the same tests, putting them religiously in a notebook that nobody but me ever reads. And I sometimes wonder whether I'm doing the right things, whether the different drugs for different conditions I have might interrelate badly or what. And the answer is I haven't the faintest idea. And that's where this process comes in, the ability to learn more about our makeup through genetic testing. And Yoli, we've heard, I was sitting here, I heard two references to government announcements on progress that's being made, money that's being invested I think both from the UK in that case. Well, as I sat in the traffic jam on the way from the airport to come here, I looked at my email, as you do, and saw a note from the Financial Times that there's a new announcement today. A new state-owned company, Genomics England, is to be spearhead the introduction of DNA sequencing throughout the National Health Service, with an initial budget of £100 million and mission to read 100,000 patients' individual genetic codes by 2017. So they heard you were coming. They heard that the lobbying that was on the list there is starting, and they've made progress. And why not? I mean, we expect when we have blood transfusion that somebody will check the types of blood we have. We expect if we have a transplant that someone will make sure that the organ is compatible with what I am. So what we're saying here is we have the scientific ability now to do a genetic test on individuals and groups of individuals and see whether the drugs provided are appropriate, suitable and effective. And if we are able to do this, then we will have the most effective treatment for me and avoiding possible side effects. We have a health system reducing the expenditure on waste and inappropriate prescribing. I am healthier, I'm economically more productive, I can earn and pay more taxes, the government gets the taxes and they can reinvest in better health services and investment and research. It's a sort of virtuous circle, and that's what we would like to talk about. Well, we've got our experts here, and we're going to hear quite briefly from the panel here, and then we're going to hear from you, I hope. And our panel, and to begin with, we're going to come to our patient. That's Barbara Moss. You've heard from the beginning of this conference, and so you know how good she is. Then we'll come to the doctor, Rob Lynn-Jones. Then we'll come to the farmer, the industry, Brendan Barnes there from FPA. Then we'll come to Keith, I think, Keith Spencer, representing the, well, he's from Europa Colon board, but he's representing the payers and providers. And then we'll come for a quick word from our real politician, the current politician, Petru, who you've heard from already today. So Barbara, let's start off.
If anyone should have died of cancer, that was me. I was diagnosed with cancer of the colon, spread to the liver, and then it came back in my liver. I was given 3 to 5 months to live. This was back in November 2006. But I'm still here, as you can see, very well, live and kicking. 6.5 years later, 4.5 years of that in total remission. When I was told I had terminal cancer, the whole family were devastated. And just like most people hadn't got a clue what to do, we were really afraid of being left on our own. The whole family was affected. I had to leave my work, that was affected. Our lives were turned upside down. I had to retire overnight, and that same night I thought about my will, I wrote goodbye letters to each one of my family, and I wrote a poem, and I even planned my funeral. It was difficult, a difficult time for my husband. He had to balance work, keeping them happy while he wanted to spend his time with me. And my 2 sons were at university. It was a difficult time for them to concentrate on their studies. I had 2 courses of chemotherapy. First one didn't work at all. I was surprised at this because I thought I was getting better. Second chemotherapy worked to a point, and at this point it was that my surgeon told me that if the tumour in my liver shrank sufficiently, he would operate. He was prepared to operate. My chances were slim with the chemotherapy I was on, so he took that gave me motivation. What he said gave me motivation, and we researched new treatments. I asked my oncologist about Avastin. It was a new medicine that we researched. And he told me, yes, it was there, it was licensed, but we would have to pay for it. So, what should we do? This medicine wasn't available for routine use, and it still isn't, but it is through the Cancer Drugs Fund at the moment. I have to make that clear. So we had to pay if I wanted it. My instinct told me that this was what I needed, and it gave me the motivation to argue my case with the authorities and to ask for help. So I went to my patient organisation, Bowel Cancer UK, associate member of Europa Colon, and I applied to my authorities for funding. I did everything I could to achieve this, but they refused me. It was frustration. I was wasting precious time. So we decided to pay help of my family, my mum, and the medicine actually only cost £4,000 leading up to the resection, the Avastin. But because I had to pay for all my treatment, it cost £21,000. The treatment worked, and after only 4 months, I was able to have an operation. My ascending colon removed, my entire left liver. And that's why I'm alive, because of what we did, because we were proactive. My clinicians are excellent, but I know my body and I know what I've been coping with. I'm aware of the possible side effects that I was prepared to take and the chance that the medicine might not work, but I was prepared to take that risk. The most difficult part for me was coping with fighting the system. Fighting cancer is all about having hope, but I was put into a situation which was time-consuming, pointless, deflating, and no one was listening to me. Empowerment is the only way forward for patients. The cost of targeted treatment is high, but with easier access, with greater use of biomarkers, patients will be more likely to receive the treatment that is tailor-made for them. I took the risk, as I said, but in the future, hopefully, this risk is going to be reduced. My belief in speaking out is motivated by the fact that I have seen and still see today patients dying who are not being given a chance. No one should have to be put in this situation, to have to fight bureaucracy as well as their cancer. So my motto is nothing about me without me. Empowerment is a popular term right now, but how do you become empowered? Some patients are too ill. They cannot take an active part in their treatment. I'm a fighter, and I'm alive today. But is that fair? Empowerment's not just something that happens to you after you've had a diagnosis. It's something that we should be in control of by taking responsibility for our lives, our bodies, our diet, by exercising. We should be aware of all these things. So, do clinicians respect me for my bold views, or am I just a nuisance? I strongly feel the main thing is that we should all be working together, and we shouldn't miss this opportunity, because it's in all of our interests.
Thank you, Barbara. That's, I'm sure you weren't a nuisance, and if you were, then you should be. But tell us how you found out what was possible. Tell us. I mean, if something happened to me, the sort of story you've told us, where would I go to look for information? Where would I find out what the new treatments are, the new drugs are? You can ask a doctor, but you sound as though you had to find out a lot yourself.
Well, the fantastic thing today is that all the charities give us so much information. If we look on any of the websites, it explains all of the available drugs and how we go about accessing them, if it's possible or if it's very, very difficult. But for me, the information at that time was a little bit more difficult to get, and we just read widely because at first we weren't sure.
Yeah.
But when we approached Bowel Cancer UK, we were explained and they helped us actually access the medicine.
Yeah, so Europa Colon's website, and that's something that I looked at before I came here as a way of finding out. Can I just say, if anyone shifts their chair back, They're likely to be over the back of this, and you'll be disappearing unexpectedly. Was that what you wanted to say? Oh, I say yes. Now, I suddenly saw this getting closer. But if you want to entertain us, then carry on. That's all right. Okay, but I think you've raised important points there. One is you had to take the initiative, and should that, I don't want you to answer me now, but let's just let our audience think about this. You had to take initiative. You were articulate. You could do it, and you had to find money. And as we heard just now from Greece, money is not always available, whether it's drachma or euros. They're not there, and they're not there in the health service, and they're certainly not there with a lot of individuals. So we've got to think of ways of affording to care in this field. But just be thinking about that, what you would do to improve that. Now let's ask our doctor. You've heard our patient now. What's your response to that? How can you be a good partner to the patient? I'm sure you are, but...
Well, I see about 300 patients a year with bowel cancer, and every patient's an individual in front of me. But do we mean individualised by the things you've heard today, KRAS and genomics, to decide whether that drug will work? Do we mean the pharmacogenomics, which is in a very early state of play, which will tell you what's the right dose, and whether that drug itself actually will give you too many side effects? Every patient I sit in front of, I usually say, coming to see me today, what are your best hopes? What are your best hopes from this visit to me? And you hear all kinds of things. Not necessarily that I want to live forever. There are all kinds of things that the patients want to achieve. They don't want to lose their hair, all kinds of different issues. Do I mean putting all those together and then going back to the MDT and just finding what the best treatment is? Well, I think it's all of those. But what happens when that particular treatment that we've decided, whether it's CyberKnife or a drug, isn't available? Do I get cross? Well, I get upset when I'm with the patient and the patient's in front of me. But in the cold light of dawn, when I'm here, do I get quite so upset? Not quite so upset, because I'm thinking, who's paying for this? Okay? And it's us, me. In the UK, 20 million households, 120 billion. My maths for that is I pay £6,000 a year for the NHS. But actually, 30% of households don't pay tax, so it's more like 10,000. Do I want to pay more? Not really. And what about Greece? You just mentioned Greece. It seems to be a sport not to pay your taxes in Greece. So am I surprised that in Europe there are inequalities between Greece and the UK? No, I'm not surprised. It's an aspiration that it'll be the same, because we write guidelines. I was part of the ESMO European guidelines for colorectal cancer. So we write guidelines to kind of edge out those inconsistencies. But those guidelines recognise that there are different support, different amounts of money, different access to things in each of those. So, am I upset? Yes, I am upset. But what about things like prioritising too? Because there are cancer, there's diabetes, there's psychiatric disease. When I went to ASCO this year, it's a fantastic meeting for colorectal cancer. But the health economics issue that most impressed me was when I was walking to a meeting, and there was a man 30 or 40 years old, homeless, carrying his trolley, and he was picking up bits of paper. Obsessive compulsive disorder. This chap doesn't have a job. Untreated psychiatric disorder. He's never going to get a job. He's never going to have any health care. He's going to die on the streets one of these days of cold. How do we prioritise him with someone with cancer? And that's what NICE tries to do. NICE is the bogeyman. But it looks at qualities. Quality of life. How many qualities would you have got this guy if you treated his obsessive compulsive disorder? How many qualities would you get him? NICE actually, although I've worked for NICE, NICE is an organisation which I have a lot of issues with, an awful lot of issues with. But you have to give it to NICE that actually those drugs that NICE have endorsed, they have driven down the price for the pharmaceutical industry. They've driven it right down. And that's why those drugs have been endorsed. Now, there are lots of flaws in the system, which mean that some drugs are never going to be endorse because they're just going to be too expensive. But we do need a NICE, and we do need patients to make a fuss and a noise. It's the balance there that's going to get things to change. If nobody makes a fuss, nobody's going to change. And so I think for me, it's a balance.
Rob, just let me ask you, you and a patient sitting in your surgery together, thinking about the future with personalised medicine possibly coming in on here, will you have the time to work with the patient to organise the genetic testing that's necessary and so on? Or is that all going to be too much?
No, it's not too much. And you know, personalised medicine is, it's an aspiration which will deliver cost effectiveness, because you'll deliver the patients for the right treatment, the right time, at the best price, because you're not going to treat patients who are not going to benefit, and you're not going to give doses that are going to cause excessive toxicity. So, yeah, personalised medicine is you know, that's part of the dream.
And also, from what you're saying, multi-diagnosis, because the cancer patient may also have depression or whatever it is that needs to be treated.
Yeah, but it's how we balance those, because you know, this is cancer focused, but I'm only too aware that in terms of quality of life, not talking about living and dying, in terms of quality of life, probably treatment of psychiatric patients has a bigger impact on quality of life than any of the treatments that we have.
Okay, something to think about. Is anyone bursting to say they recognise some of the problems that either Barbara or Rob have been talking about? Yes.
I'm a similar case as Barbara, only 1 year later, I think. But being a German, I had a completely different treatment. And I think it's a question of political philosophy how to look upon the national health system. And since yours is taxpayer-based and ours is individual contribution, insurance-based, there's a difference. And it is not the government who is, in this case, administrating the taxpayers' money is cruel in some way. And in our case, since it is not the government, since it is the health insurance and the organizations of the medicines, so there is some regulatory interface in that. And I think at the end, the costs, the total costs are the same. They are skyrocketing in Britain, they are skyrocketing in Germany. But I think it is also a question of morale. And we heard about ethics. And I think that is also something which we have to look at as something which must be changed. Because I'm suffering with you.
Okay, well, we might bear that in mind when Petru comes to respond, because part of that is about differences between member states of the European Union. And we know there's a different, what we call the Beveridge system and the Bismarck system. But there are many different ways of treatment and priorities and so on within countries and literally within regions of countries. Some of your lender may have different policies than others. So if we're going to have solidarity within Europe, how do we overcome that? Yeah.
I'm also a gastroenterologist seeing patients that have to tell them the bad story, the bad news. As a gastroenterologist, I also often have to tell the patient the bad news that they have colon cancer. But my impression is that nearly 9 out of 10 of these patients don't know anything about colon cancer. And so they don't know anything about eventual treatment. So that's the information that they need. We are living in an information society. We have all these internet, social media, we have everything we need. And I would suggest that we make a law that every pharmaceutical company has to spend a minimum of their budget of the research on information and education of the people.
Okay, well certainly in our European Alliance on Personalised Medicine, education and training has been one of the key issues that we've been looking at there. And that goes both for medical training and also for patient education and training. Because if they're going to be greater partners in the personalised healthcare, within which personalised medicine sits, then they need to understand how to achieve that. But you've thrown the gauntlet towards the pharmaceutical industry, so that's cue for Brendan to respond.
Okay, well, thank you for inviting us. It's always a bit of a challenge because I'm sort of following two people who deal with, one who is a patient and another person who deals with patients, and I don't. I work for an association, so it's a bit more remote. We're talking about the controversies of personalised medicine, so let me just sort of, when I came to this, I actually thought I'm not quite sure what the controversy is. Because from our perspective, and if I just think about drug development, I think we're going through a process which is a bit like moving from the sort of inter-office memorandum to the personal computing era in terms of the way things are going to work. It's that dramatic for us. But it's not negative. It'll be good. We're just not quite sure what it's going to look like in 5 or 10 years' time. And, you know, what are the obvious positives? The other obvious positives are that drugs are going to be used more effectively at an individual level, but also at a societal level. I think out of that, you know, we will probably get things like better patient adherence. We will also probably have a wider portfolio of drugs because we have things falling out of development now because the development process is relatively insensitive. When the development process is sensitized, you may be able to retain things that are useful in some cases. So I think we don't quite know what it's going to look like, but we're very positive about the future. And I think, as one or two other speakers have emphasized, what we're particularly concerned about now is that the process by which we get the medicines approved has to catch up with what's actually possible. It has to catch up with the science. It has to catch up with the fact that, you know, in the past, I think we tended to have this model where you did your phase 1, 2, 3, you got approval, and then things happened in the market and people weren't too sure what was happening. And where we're going to is something where, you know, the experience and the accumulation of knowledge about a drug is going to be lifelong until the last pill has been used and it's been taken off the shelf, which could be 50 years hence. And that data is going to be captured, and it's going to amend the way the medicine is used throughout its life. I mean, if you saw the presentation from Dr. Wassam, which I thought was an incredibly complex description of how clinicians can use different combinations, that's the future. Again, it's very exciting. We have to figure out how on earth do you approach deciding which development projects you invest in with this much richer but potentially much more uncertain environment. But one of the things we clearly do need is a modern regulatory approach which reflects the advances in science. I think that for me a subtext to what we talked about today was that what I said was about drug development. A lot of what we've talked about personalisation has been much more patient-centred. It's been about multidisciplinary teams, that sort of thing. And that's an aspect of this which really needs to be explored, is what is the role of the patient and how did the patients feed back into this innovation process. Perhaps that's not, again, you know, you would say with what's happened with the use of data in every other area of our lives, it's pretty obvious that that's going to be a much increased role, but we have to figure out how it's going to work. So I think for us, the controversies, it's going to happen. That's not a controversy. Will it be a good thing? Yes. The control, you know, will we have to handle massive levels of complexity? Yes. The controversies around things like how do we implement change? I mean, you know, if I heard one thing today, and it was just corroborated by the last statement someone made, is national situations are different. Lady in the front row said every doctor is trained differently in a different national system. They have slightly different backgrounds, slightly different emphasis. Does that matter? What's the model for interaction? How do we collaborate? Do you remember the Olympic rings? I think, and this will probably be uncomfortable for some people, but we believe in the future, in line with that point I was making, that the sort of generation of knowledge about the medicine carries on throughout its life from now on. That the people who make the medicines have to be embedded in that information gathering process somehow. Otherwise, we're shooting in the dark. And that's not efficient. People raise the question of cost. I mean, 2 points there. How much do we want to invest in healthcare? The only thing I would say is I'd encourage people not to get trapped into the accountancy mindset of saying there is a right percentage of GDP to invest in healthcare. I don't think there's evidence for that. People point to the US, but I think the point in the US is not how much they spend, but how badly they spend it. I read an article about a Nobel Prize winning economist who was talking about healthcare. And he actually compared it to listening to an orchestra. Because an orchestra is full of extremely skilled individuals and they have to work together in collaboration. And he could say an argument, whereas today, yes, you might spend a certain number of euros to see a top-class orchestra, and in 50 years' time you might be spending a lot more. But you may still be able to afford it because of evolution elsewhere in the economy. His point was that it may be that you don't get there's nothing wrong with expecting healthcare expenditure to increase. Clearly, as we have to have a sustainable economy. But just to say, it must be 10% of GDP, I really encourage people not to get trapped in that mindset. I don't think there's any basis for that. So I think that, those are the main points I wanted to make. The last point was just about the EU particularly. I said we have to think how people can collaborate across member states. One of the things that we have completely failed to tackle as a union is that we still can't, or perhaps people in Brussels can't seem to get their heads around the fact that some of the member states are richer than others. And some of the member states are able to afford healthcare more than others. And we still have a very sort of uniform, everything has to be the same mindset. And it's not realistic. I mean, it would be nice if we had complete economic equality across Europe, but it's not going to happen anytime soon. And so if we want that equality of access to healthcare, we're going to have to recognise the differences in affordability that exist now and are going to exist in the medium term.
So you would actually attach your pricing to the GDP levels?
This is something that we're having to look at across the whole world. Europe is no different. The only thing is that in Europe we have a sort of a bit of a mental block about acknowledging those differences.
And then you'd have to hope that they weren't resold to other countries. But that's we won't get perhaps into that debate. But if there's some bold statements there on financing that you might want to pick up on the way in which we look at the cost of drugs and treatments. And also, I didn't hear the answer to the challenge, which was, should there perhaps be a levy? I'm putting words into your mouth, but a levy to pay for some of the training that might be necessary, or are there other ways in which you can help the GP and the patient understand that in future the drug they've read about in the newspaper may not be appropriate for them? Because if that isn't understood, then the pressures, as I've known for myself from in the past as minister, from pressure groups, from NGOs, from the media, that vast numbers are being excluded from, as happened with beta interferon and multiple sclerosis, that becomes quite difficult to manage. And of course the temptation is that you give in and you waste money. So can you help with that?
It was a very interesting comment, as you know, we had a legislative initiative at European level not too long ago about information to patients, which rather went against the industry communicating at all, which we found bizarre, because everything we do say is very heavily regulated, and when we're in an internet era where people can access completely unregulated information, it seemed to be strange to regulate the people who have most at stake in communicating responsibly. So I think legally we couldn't do it at the moment. I think it's an interesting idea. I guess, based on what I heard today, again, I think you have to think about how do you get the information coming out about what works from the healthcare system. Because, you know, particularly I believe in this area, clinicians experiment with combinations. They see if something will work. I don't think you're going to get a pharmaceutical company saying, patients, you should try this, because we're extremely conservative and risk averse. I mean, you know, unless the EMA have told us you're allowed to say it, we won't say it. So I think if the question is how does a patient find out what is the cutting edge information about the things that work, that requires quite a lot of reflection. You know, I'm sure we'd like to do it, but I think there would be things that would be difficult for us to step up to, because it is the clinician who is at the cutting edge, I suspect.
Yes, but just as we heard in one of the presentations, the Herceptin case, which I always thought the figure was that it was about 1 in 4 of patients would qualify to benefit from that drug. I think this slide suggests it was 1 in 5, so it's even lower. So those sort of things are out there and they're known. But it's a question of explaining to the patient to say, actually, you're not one of the 1 in 4 or 5.
I think we would like to be involved in that. I guess what I'm saying is I think there's a process of evidence generation by which you start off with something which is uncertain and it gradually becomes confirmed, reinforced, and so on. And you need to think about it in that context.
Okay.
But yes, we would like to be involved in that.
Good. Keith, you're on the other side of that equation. Representing the payers, but also, of course, the voice of Europa Colon here?
Well, definitely not the voice of Europa Colon, definitely the supposed voice of the payers, and like every good administrator, I have prepared a statement. We are, of course, sympathetic to people's feelings. Clearly, an individual cancer patient, their family, their colleagues, their friends, will have a very clear view of what sort of treatment they should be getting. However, administrators and healthcare policymakers have to regard issues from a completely different perspective to those directly affected by disease and ill health. Payers and those who set policy must consider broad and non-personal issues such as overall costs, benefit to society, economic returns, available budgets, etc. Now, this may appear at times inhuman, but healthcare systems have to be run according to the financial constraints which exist. And in terms of financial constraints, we hear so often these days we have ageing populations. The number of people above retirement age is increasing in all countries. So there's not just an increasing incidence of disease because of ageing populations, disease which includes cancer, but there's a reduction in income for the health systems. And if you couple this with the recent economic difficulties everyone has experienced, and increased unemployment leading to further reduction in contributions, you're getting increasing pressure all the time on health systems almost everywhere, and it may vary from country to country. There's not an inexhaustible supply of money either for cancer treatments or in terms of total healthcare system expenditure. Generally speaking, healthcare providers are obliged to use methods like HTA, Healthcare Technology Assessment, or to refer to organisations such as NICE in the UK, which was mentioned earlier. And the money available for health has to serve an entire population equitably as far as possible, and there will always be choices to be made. Often there's not sufficient data available or made available to justify extra expense, and definitely cost effectiveness needs to be proven beyond doubt. If we massively increase financial spend in support of expensive treatments for cancer patients, this will of course reduce the total amount available in other areas. Now, who is going to set priorities? An older individual and their family suffering from cancer will be very grateful to extend their survival by just a few months. But what if the cost of that means denying treatment to a younger person who might then enjoy a much greater number of extended life years and make a significant contribution to society and consequently create economic benefits? There are constantly many new and amazing breakthrough products introduced by the drug industry, and it's clear that research and development of new treatments and products requires large amounts of investment. However, we do believe the pharmaceutical industry could do more to broaden the availability of life-saving or life-extending drugs by implementing more imaginative pricing policies. Many people criticise healthcare systems and governments for not providing adequate services and care. Yet, in many countries, there are those people who are happy to spend a lot of their own wealth on leisure, entertainment, holidays, etc., but do not see good health as a commodity to be purchased rather than as a right or an entitlement. How many are prepared to pay additional money to protect themselves or extend their survival rates? Who wants to have their taxes put up if everybody wants equitable healthcare everywhere and a perfect health system at home? You're going to have to put your hands in your pockets because, as I've said, the money is not there. On perhaps a slightly uplifting note to end this official statement on, if providers in general can be persuaded to move towards prevention by whatever means, screening, health education, improved early recognition of risk groups, etc., there's a real possibility that money could be diverted from costly, what I call fire brigade treatment of sick patients to wider groups of healthy people to significantly reduce the later need for high expenditure on seriously ill individuals. That will obviously take a long time. Bottom line message at the moment is we haven't got the money to do it.
Thank you, Keith. That's a robust statement, I think. I used to think, too, that young people should get all the priority. And, as the years go by, my definition of young changes. Do you have a definition? Where's the cut-off point in your scheme of things? My age.
When I no longer feel able to get out of bed in the morning, I'm old.
When you go to bed? We won't go there.
Not so much.
No. Just as a matter of interest, this issue of topping up, it crops up occasionally, and certainly it was inherent in what Barbara was saying. Do people here think you should be allowed to top up if you're prepared to, if you can afford to? Or is that somehow taking advantage of your comparative economic status compared with people who can't afford to top up? You want the whole lot paid?
You're not paying enough tax.
That's one answer to it, but I want to put that to one side for a moment. Assuming that there is just not enough money, and there probably never will be in the pot to cover everything.
There are billions, according to Petru. For research, but...
Research development,
Well,
and the program Health 2008-2013 as well, 365 million euros, also unspent.
For research, not for...
No. The health program is not only for research.
Can I just add another comment, if you will? This comes from the Economist Intelligence Unit report on European healthcare systems. Across Europe, healthcare is barely managing to cover its costs. But of even greater concern, the costs themselves are set to soar. According to World Bank figures, public expenditure on healthcare in the EU could jump from 8% of GDP in 2000 to 14% in 2030 and continue to grow beyond that date. The overriding concern of Europe's healthcare sector is to find ways to balance budgets and restrain spending.
Well, then we have to pay less for drugs. Drugs can't be so expensive. I'm sorry, Brendan, I have an issue here. If we can if the clinicians are talking about doublets, triplets, 4 biological agents being used to treat one patient, we're talking around 75,000 euros to treat a patient. Where is that going to come from? You've got to lower your prices.
Well, I think that, I think I described one side of this in my initial comment. The dilemma that we face with what we're talking about here is that if you go down the road of personalised medicine, and I said we see this as a wholly good thing, it means that you have smaller groups of patients who will benefit from any medicine. And at the I think we had a number of presentations where people said, whatever you want to say, it's 30 or 40% of the patient population that are being treated now actually benefit from the medicine. We know many people don't benefit from the medicine. And it's a good thing, societally, if people who don't benefit from the medicine aren't being given the medicine. If I'm bluntly commercial about it, the dilemma is that means your market is 30% of what it was before. If you still have, on the cost side, a product development process which is barely economically sustainable when you are treating 100% of patients, it is completely unsustainable if you're only treating 30%. And this is why I was saying, for us, the economic importance of getting the product development aspect, the regulatory aspect of this right, is it brings things back into proportion. We focus the development process as well on the people who can benefit. It probably means smaller trial sizes. It means that medicines go to patients earlier, but they're monitored for longer post-approval. And we try and reshape the paradigm so it actually is more affordable. But
okay, I want to bring other people in, if I may, but we'll continue that. But yes, please.
Hi. So just a couple of thoughts. Firstly, I absolutely completely agree with Yola that the price of medicines must come down. However, I don't think that the pharma industry is the only bogeyman in the room, actually, and I don't think there is ever a case for it to be an either-or, that, as my dear friend Roglin Jones was talking about, I don't think there should ever be a case that we have to compare saving the life of a patient such as Barbara with curing someone's psychological disease or illness. I think that's absolutely, if we're getting into that, it's the wrong place to be. I do think actually that some of the problem here is actually in the world of politics, and I think there's a lot of responsibility, which kind of leads to a lovely Romanian MEP, that actually about governments taking much more of a proactive, holistic look at how they can best spend that money and making some priorities. And I think actually it isn't about just that targeted therapies are absolutely not going to be the only solution here. I think actually some of the solution is in prevention and early detection, so that there are less patients who are needing the treatment. I think for those that do need the treatment, targeted therapy is absolutely vital. And I don't ever believe that there should be a case where some patients can pay to top up and others can't, because that just creates a whole world of inequalities where the poor continue to die and the rich continue to live. And that needs to be about political will.
Good. That's the question I was asking. That have an answer. Can we bring the microphone round to the front? It's coming. Look over. Oh, yes. Yeah. No, here. Here. Yes. No? I think you wanted to. Oh, you throw me, but I've been rescued from behind.
My opinion is that it's not necessary that every patient know everything about medicine, about new medicaments, because it's so difficult to know. It's so fast changing. They must just trust the doctor. It's only thing patient need. If they trust the doctor, they will trust that medicine doctor give to him will help him, and it works then.
Yes.
I'm sure.
I trust my doctor until I've read some article which suggests that there's an alternative. And then I ask him about it. And then we discuss it.
Yeah.
But I think we need to be able to do that so that we can have a sensible discussion. Yes, you listen to his expertise, and yes, 90% of the time I accept what my specialist tells me. But 10% of the time, I'll give you one example. I read about a diabetes drug which sounded as though it was a better type of cure than the one I was taking. I said to my specialist, do you think I should try it? Well, he said you could. So I said, what's the downside? He said, oh, nothing much. You might occasionally get a dry mouth, and you might sometimes slur your words. And I said, no, as a politician, I can't slur my words. I'm not doing that one. So I decided that one, but I listened to him. And you're right, but it's not the whole picture, is it? We have to help patients to understand more so that they can not challenge, but take joint decisions.
But they know more already.
Yeah, absolutely.
But you have many people, they are coming in the hospital first time in life with cancer diagnosis. They don't need philosophy about medicine.
Yeah,
they need a human being,
absolutely.
a doctor
I understand.
who he can trust.
I understand that, and their carers do too.
Yes.
They need to.
And I was growing in ex-Yugoslavia 50 years. We were a very good system, which now falling down. And we can't believe that there is no possibility to help each other.
Yeah. Which country now?
Slovenia.
Slovenia. Well, Slovenia actually had a good record on spending on health. So perhaps it goes back to that point about percentages. No. Yes. Yes, please. Can we have the... Sorry, were you waving behind my back? Right.
I had three questions and I forgot all about it. But what I want to say and what I want to know, that we, the patients, must take our point into the government. Don't ask for money. Don't do that. But be strong. Be like the Red Wives in the 70s. I don't know if that was also in Europe, but in the Netherlands we had the Red Wives, the Red Wives, and they went out in the streets and they were shouting for what they want. And I think we have the task to do that. We as patients, I think. I don't want to speak about money. I want the government to know how important it is to know, and it is not so costly. And they are giving millions to tanks and whatever.
Yeah.
Let's spend it on drugs and doctors.
Yeah. Can I say you're 100% right? That with one tiny exception, and that is when you talked about them shouting. Don't shout, otherwise politicians can't hear. You have to go and get alongside them and persuade them that it's their issue too. Show them what can be done. Show them what the cost of doing it is. Show them what the cost of not doing it is. And my experience then is you've got a friend for life. But Petru, come on. This is your cue.
Wow. This is actually the kind and the way of discussions we have. I'm used to in the politics and the European Parliament at national political level. Because these kind of controversial discussions lead to constructive ideas at the end. And this is what we need, actually. That's why I'm very happy that you raised so many problems. Well, most of them related to political decisions, no matter if we talk about national or European level. Like I said in my introductory remarks, we cannot say up to the end that this is not an EU competence and we cannot do anything at the European level. No, there is money, there is budget, there is legislative framework which can be elaborated and proposed to all the national governments. Well, but let's come back to personalized medicine, because I understood this is our topic today, which is a new concept which I personally support a lot. And I really and truly believe that this is the future of medicine in the European Union and the world. But let's start in the European Union. Even we still have these huge discrepancies, huge differences at the healthcare systems among the member states in the European Union. You're right. I will talk later a little bit, very shortly about this, because this is extremely important in order to achieve common and concrete results. But let me draw your attention on two keywords related to personalized medicine. One is partnership, and the second keyword is innovation. Partnership doesn't only refer to partnerships between you as representatives of the patients or representatives of pharma industry or representatives of hospitals and governments or parliaments, but we need partnerships between healthcare systems from one country to another. We need partnership between educational systems from all the member states and the EU institutions. We need those European associations which consist out of national associations of patients, of hospitals, of pharma industry. And those all together, only together can build up new concepts. And this is what we have to understand. This is, in my understanding, in my eyes, partnership, real partnership. And then we need a link between educational system, healthcare system, and a legislative framework. And this means partnership. I myself wrote a letter to all the ministries of health from all those 27 member states in order to implement a register for patients at European level. This was a new idea of mine, and I thought this is necessary to have a starting point, to know how many people affected by cancer, by colon cancer, we have in the European Union in every single member state. And then we know what the next step would be, what the procedure we can use, what amount of money we should allocate for that, how much should we invest in research and development, and so on. That should be the concrete approach. Second key word is innovation. Well, innovation, as I've told you for several times, and I'm repeating that every time I get a chance, this money, which represents also the objective of the European Union, as you might know, the first objective in the EU Strategy 2020 is innovative or smart economic growth. That means every single country has to spend 3% of its GDP on research, development, and innovation. That means we know that we in 2020 should have new concepts, even in healthcare systems. But for that, we need to get involved, and we need a lot of information. And I will draw your attention on some activities, some concrete actions at the European Parliament's level. We already discussed about how to update the rules on medical devices. This is one concern of us. Then on clinical trials, which we are already working on. We discuss within the directive of data privacy, how to transfer data from even patients' data from one country to another, or from one hospital to another clinic, or whatsoever. You might have heard about Directive 52, 2012, the standardized receipt. You can now get the receipt in north part of Romania or Slovenia or whatever, and you can buy the medicine in Munich or Vienna or even Barcelona, which gives a lot of more flexibility. All right. All right. A lot of more flexibility to the patients, and this will also stimulate pharma industry to adapt their strategies and their new innovative concepts to the needs of the patients in every single country. Well, there is a lot to say about this, but as I am a friend of dialogue more than a monologue, I will leave some time for questions. Thank you.
That's great. Thanks, Petru, and good luck with all those. I know that some of those are not to say controversial as they're being discussed in the Parliament, like the medical devices one, which I gather is a hot topic now. Just last question from the floor. Yeah.
Thank you. Thank you. My name is Kaisa, and I'm from the European Patients Forum, and I have a sort of comment and a question, I guess, more to our political decision makers here. And it concerns really the concept of partnership and how to spend healthcare money wisely where it's really needed and makes the best difference. And, you know, we think that patients are an equal and legitimate partner in this, or should be at least. And this works both at the individual level and the collective level as well. I mean, it's been shown that when patients are really engaged in the healthcare decision-making process, that they tend to choose not necessarily the most expensive or the most complex and aggressive therapeutical intervention. And in fact, there was a very interesting paper that was published last year that showed that listening to patients' preferences genuinely resulted in not only better outcomes, happier patients, but also better cost effectiveness. This was done in the UK. Yep. And at the political level, I'd really like to stress the value of patients through our representative organizations. We can really point out what works and what doesn't in the way the healthcare is delivered, organized and delivered, so that we don't waste money on things that patients don't necessarily want. And I wonder what you as politicians could do to drive this at the European level and also in the member states, the recognition of patient organizations as partners.
Okay, we don't have time to get you the answer, I'm afraid, publicly. No doubt we can continue the discussion afterwards. And
John's got to leave.
Okay. All right, in that case, let's hear the response.
I stressed out the need of synchronization between the healthcare systems among Europe. But what I would like you, as representatives of patients, to do is to take the lead. I recommend you to take the lead. Please believe me, politicians have different concerns and different obligativities and duties at the party level, political level, parliamentary level, and sometimes they don't have enough information. I'm trying to get as much as possible and as much as I can understand into details, but there are not too many colleagues of mine which do like that, and that's why your contribution is crucial in this regard. My advice to you is do not expect someone else to take the lead. And this is my clear message to all of you, no matter which area you are coming from, which country you come from. Take the lead, come to the European Parliament, come to the politicians, propose something concrete, propose the strategy, discuss about the concrete strategies. Like I was talking to Julia on the floor, if you come with something black and white, these are those 5 or 15 or 25 needs and problems we have in the colon cancer area at European level or in one single country. And that's how we see that we could improve the situation by changing the legislative framework at national or European level, by allocating more funding to achieve that. And then I will invite the European Commission, the responsibles, the direct responsibles from DG Health, from the European Commission, to stand or to sit in front of you and to take it over. Then I will be the one, together with my colleagues from the European Parliament, to push up or to put pressure on the European Commission to change something in due time. And this is the way I see how to achieve concrete results in a short period of time.
Okay, Petra, thank you very much. And so just to add to that, there should be a twin-pronged approach, I think. One is through the organisations, through the patient groups and so forth. The other is as individuals to your own local member of parliament, whether it's an MEP or an MP. Because I can tell you that if I, as I did, had people coming to me who lived in my constituency, they had votes. And you listen to people who have votes.
That's the problem. The politicians interfere too much. You have too much say in what we do. No, you do. You're beholden to yourselves to re-election.
Well,
if you left us alone like the Bank of England and had a separate organisation that you did not interfere with, we would do much better.
Okay.
I was actually very tempted to say the same thing at one point, and I'm not allowed to say it because it's not the party position. But we had the presentation earlier from Dr. Wassam, which was a picture of absolutely explosive innovation in this area, and I almost sort of thought you just want to let that run, as long as people share the innovation, share the learning.
Okay. Point taken, point understood, both of them. All I would say is if what you need is a change of policy by a government or by the Commission, then you need to have the intermediaries who are your elected representatives, and they will listen, and then they'll persuade the terminals to listen. Let me just hear one last point.
I'm a gastroenterologist from India.
Come and be the politician for a day. Thanks very much, and thank you to the panel. Thank you,
Well, I'm really not sure I should be the one that's moderating it, but anyway. Okay. Anyway, we do have another question here. Let's hear the question.
Yeah. I'm a gastroenterologist from India. Just giving an Indian perspective to the discussion that we are having. We have about 35,000 colorectal cancer patients every year. More than half of them are advanced. Less than 1% of them who are eligible get targeted treatment because we are a self-payer system. There's no government insurance. Our per capita GDP is about 200 euros a year. Cancer treatment generally costs about 1,000 euros a month. Majority of our patients are elderly and their families do not even take them to an oncologist, let alone treatment. People have to sell their houses, farms, jewelry, take big loans for treatment. They can get treatment only if they have insurance. This is usually with the younger crowd, software engineers, those who are employed in the organized sector. NGOs help some, but those numbers are dismal. But what we have is innovation from Indian companies. Just to give you an example, sorafenib, the drug that is used for liver cancer, hepatocellular carcinoma, when it was launched, it used to cost 5,000 euros every month. 5,000 euros, which was out of reach. Patient used to come with HCC, they were told there is no treatment. Because you tell them there is a treatment, they will sell everything, set their families back by 3 generations. And the day after an Indian company launched, the cost came down to 50 euros per month. That is an impact. So if you have monopolies, you will have high costs. You have competition, costs will come down.
Well, the whole issue of generics is a completely separate issue. I take the point that what we might call the third world suffers in many ways in health because of lack of resources. I'm not sure that generics is entirely the answer if we want further developments in the future.
I mean, I'm happy to respond on that. I mean, well, I make one point straight away, which, you know, you said yourself. I think something like 80% of healthcare in India is privately funded. The public system is negligible to non-existent. And that's a political choice. You know, bear that in mind. I mean, India is, you know, a country of enormous economic diversity. They have chosen not to have social insurance, just as European countries have chosen to have it. The contrast, I mean, you know, there have been a lot of high-profile cases like this. Our members are trying to figure out how do we make medicines available in emerging economies, particularly economies like India, where you have sectors of the economy which are essentially quite wealthy, and you have large parts of the economy which are very poor. And it isn't easy for us to do it. We're still learning it. To say the solution is just to make everything generic is, of course, to miss the point that generics don't develop new medicines. So it's, you know, fine. Once someone's developed the medicine, yes, you can take it away from them and make it generic, but, you know, it doesn't solve the problem of how do you fund the innovation in the first place. So I recognise the impact that that's made. All I can say is our members are trying to figure out how we operate in these markets, and it's not easy.
Anyway, I was very much on board with the notion that patients and we as the general should be making decisions and not politicians. So let's hear any other questions and comments from...
Well, in Europe we have concrete data, like numbers. European people are getting older, so new cases of cancer will emerge. On the other hand, if you say the pricing or about targeted therapy, it's getting much more per percentage, just many times over the gross national product. So by the year 2025, it must be not affordable for any country, the cost for pharmaceutical companies. So something have to do. On the other hand, okay, we trust our doctors, but how to trust to committees? Like you know, the case that was from EMEA, permission for 15 days of overall survival, like the case of Tarceva in pancreatic cancer. We have the approval. A terrible amount of money just for 15 days. It doesn't make any sense. So something has to do in the European Parliament. There is pressure from the patients that we have new tools. We have new therapies, very promising, like personalized medicine. But how it comes to cost too much? It must not be affordable. And the case of Canada, who is not South Europe, it's not United States. How the society of Canada thinks that the price of the drugs is very, very high, is not affordable. And another question, is there any limit for the drugs we have to pay? I said the example that the metastatic colon cancer, the clinical benefit of the last target therapy, the last 10 years, there is a special article on CCO, improved by 2, but the cost raised by 340. Is there any limit to that? Maybe in Canada it's 5,000 or whatever. What about Europe? So how much to lobby in pharmacoeconomics? Not lobbying by patients, but you have to do something on the other part.
Well, your point about Tarceva it's exactly about personalised medicine, because if you had a particular biomarker that would tell you which of those patients benefited, then you would probably be able to treat a very tiny percentage of those patients with Tarceva, and they would benefit. Yeah, but I mean, the problem for me is that the pharmaceutical industry does not embark as much on biomarker development as they should. I mean, there are some very important drugs for which we have no biomarkers, and that way all patients get the drug. I mean, I'm sorry to be cynical about that, but there isn't actually a driver a lot of the time for you to develop biomarkers, because everybody gets the drug. Any other comments from the floor?
If I may, I understood that was addressed to the European Parliament. That's true that the life expectations raised by 2.7 years compared to 1990 in the European Union. And that means that the healthcare systems become more and more unsustainable by the decreasing economic development in the last period of time. Of course, this is a concern of almost every country, or almost every government, how to support these expenses from which revenues. And that's why we think increasingly at the European Parliament level that there is an increasing need of harmonization for the healthcare systems at the European Union, and even identify clear resources for that, but also set up clear rules in terms of limits of prices. And this is a huge debate, and we have here Brendan, who will have a different opinion maybe.
I think we're going to have to draw things to a close.
Yeah, and that's why we have to, let's say, come to a common conclusion to the pharma industry, because we need them, they need you, and we are somehow in between. And that's why we need the communication.
Yeah. Okay, so I'm going to ask the panel, if there's no more questions from them, to have one final comment, a very, very brief comment from each of you as a final. Barbara.
When we talk about the cost of personalised medicine, have we thought about the cost of not going down that route and what will happen? When the government, if a country is attacked, the government doesn't just get the army in place at the last minute. They prepare beforehand and they're ready. And that is what I think as patients we should be pushing forward.
Okay. Final comment, sure.
That's exactly the point. Well, I'm waiting for you in the European Parliament to continue these kind of discussions, and my message is clear to you: come up with idea, and we will support you.
Thank you.
Whatever else you want additionally out of your health systems in the future, I'm sure it's going to cost you money one way or another.
Okay. The cost of drugs is not going to sink European health systems. What is going to sink European health systems is our obsession with the accounting numbers and our failure to invest in prevention, in using data better, and providing more effective treatment outcomes.